Welcome back to Reimagining Cyber, the podcast where we dig into real-world cyber challenges, the people tackling them, and the innovations shaping the future. My name is Rob Aragao, Chief Security Strategist at OpenText, and today we're diving into a critical issue, the connection between cybersecurity and healthcare. Think about it. Healthcare is one of the most targeted industries when it comes to cyber attacks. And the risks aren't just about data breaches, they're about human lives. And we are going to focus on a key part of this that's gaining more and more attention, the connection between medical device security and patient safety. Joining us is someone who's been on the front lines of this challenge, Ed Gaudet, CEO and founder of Censinet. If you're in healthcare cybersecurity, you probably have heard of Censinet. It's a cloud-based risk ops platform that is purpose-built for the healthcare industry. Ed, welcome to Reimagining Cyber. Glad to have you here.
Hey, thanks, Rob. Glad to be here.
Many different challenges. One of the key challenges is also dealing with these a bit outdated systems, some of the older legacy embedded Windows platforms as an example. What are some of the things that you're seeing out there that help overcome those type of legacy-oriented challenges?
Yeah, you're getting right into the
meat of it.
Into the details, right into the yeah. So, but part of the problem with medical devices, I think, as you've identified, is that many of them are dealing with legacy components, whether they be an operating system or some other software. And the reason this problem exists is because of the FDA post-market approval process to get those systems updated. And so there are a couple of different strategies that a health system could apply as they're thinking about dealing with these outdated operating systems. First and foremost, you could retire them, right? It's literally implement a phased roadmap approach to the retirement of those and bring in some new devices, whole cloth new, right? But that can be expensive. You can patch those systems, so you can have an aggressive patching strategy that allows you to patch those systems as updates become available. But again, that requires you to shut down your devices, which means you've got to be thoughtful about when you shut them down because you have patients connected to them, right? So you might want to take a phased approach to your patching, or you could isolate those systems using micro-segmentation on the network. So you could take a VLAN approach or some software-defined perimeter control approach to that micro-segmentation. So those are typically the approaches that people will take.
It's interesting. I draw parallels to your description as it relates to, again, the healthcare and the medical devices side of it, to some of the previous guests we've had on, which is at the end of the day, it's how do you deal with these legacy systems? So we've had, conversations with NASA. Well, how do you deal with these, in-flight systems? How do you deal with these different, kind of ground controls? And you've had conversations around national labs and critical infrastructure elements. I mean, think about some legacy systems there, right? So it continues to kind of exasperate itself. But those are some good ideas and perspectives on how to kind of potentially help alleviate those issues that we're seeing out there. In addition to that, what are you seeing around some of these kind of real key approaches that are working in regards to biomanaged devices and that kind of balance of cyber security with risk management? And I know, you and I had a kind of an offline conversation on this topic, which is that your viewpoint of this kind of major issue and how they're siloed today between risk management and cybersecurity and the issues behind it and biomed. Talk about that, if you will.
Sure. Yeah. Healthcare in and of itself is complex, right? So you have different functions. Some are critical in the delivery of care. Some are administrative in nature. Some are operational in nature. And so when it comes to biomed managed devices, because of the complexity of those devices and all the requirements associated with things like the FDA, things around like you said, the legacy approaches to patching, right? Which is very different than you would patch another system that was not a biomanaged device. Those typically have been managed under the biomed group, right? So the biomed engineering group will act as a risk management organization, if you will, a silo within the context of the overall organization. So you could have risk management under, and most hospitals have risk management under the IT, specifically the security group typically under IT, but sometimes it can be peer to IT. But biomed tends to be in and of itself, set aside to manage the complexity of those devices and the patching, the risk, the risk assessment of those devices. And what we found based on research is that when those organizations are flattened, meaning that they're not managed in silos, the organization is demonstrating better coverage of and better compliance with a NIST cybersecurity framework, for example,
Okay.
right? So
Yeah.
because they're not split, you're not duplicating efforts, you're not duplicating expenses. So there tends to be a much more efficient set of outcomes when those are under one organization versus split or bifurcated.
Yeah. So bringing them together, to your point, because at times the pockets are doing different things. Even to your point about this CSF, that they may be interpreting it and applying controls differently than when they come together as one, right?
Exactly. That's right. That's exactly right. Or they might be using a different framework, right? And so getting they may be duplicating resources. So imagine you put that under one organization, and maybe there's one central system or source of truth that manages all risk, including SaaS-based applications that are administrative or operational in nature, medical devices, right? It's all under one roof. So you get a holistic view of risk and you can manage it with the same set of resources, if you will.
That makes sense. So everything kind of rolls up to be that single source of truth perspective, if you will, under one
Yeah, and you
umbrella.
can still have, you could still have an organization that you matrix in subject matter expertise, right? So you could have within the biomed organization these risk-based SMEs or architects, if you will, that are providing the guidance or part of the review process, but still it's being managed centrally out of that one application, such as the Censinet application.
Yeah. Yeah. So what we've been talking about so far, and correct me if I'm wrong, Ed, has been more so about like a hospital environment you kind of alluded to, and again, bringing them together. What experiences have you seen as it relates to the medical device manufacturer and product security teams within that manufacturer? How has that kind of started to mature? Is there more alignment to, the FDA and some of the guidance there? Like, just out of curiosity, what are you guys seeing in that area around product security specific to the manufacturer side of these medical devices?
Yeah, I mean, first and foremost, getting identifiers uniquely established so that you can tag your devices appropriately across your organization. You can leverage asset discovery tools. There are plenty out there. Scenario, Order, Metagate have those. And you can start building appropriate contextual metadata so you understand where they are located within the context of the hospital, within the context of the patient population, the criticality of the device itself. Maybe this device has a different patch SLA than the other devices. So you can really start to categorize and manage them based on not only your overall framework, but also as threats and vulnerabilities appear, you can put the right level of resolution on top of those based on, again, your tiering and your approach.
Yeah, makes sense. So you're really doing, again, at that point, it's much more kind of risk prioritization that drives, right, what you're going to put attention on first.
Risk in the operations of dealing with the risk, right? So it's taking that data and taking action on the data, right? So it's not good enough to just understand the aspect of risk, but it's also, you want to tie that to action. You want to tie that to some type of ability to put a control in place that reduces risk over time. And so that's what's really important about, combining those into a single source of truth, if you will.
Makes sense. Yeah. Sounds like it's a very good value-based approach in that model. So let's talk about kind of the patient safety connection point here. And we've seen, obviously, especially in the healthcare vertical, tons and tons of different cyber-oriented attacks and major issues associated to those attacks, outages, and ransomware being a big part of the equation, of course. But when you kind of scan this space that you focused in on for quite some time now, what are some different types of really disruptors around patient safety specifically that you would kind of call out? Is it really typically the ransomware side of it? Are there other things that you're seeing pop up?
I mean, there's a number of different risks to the organization. It could be as simple as the HR is down for a reason other than a cyber attack or ransomware, right? That could delay orders. That could result in rerouting of care through manual processes. If you do have some type of event, whether it be cyber or otherwise, not only could it affect the EHR, but it could affect your procedures of intake. So, for example, you've got people coming in through ambulance. What happens to those folks if you can't take new patients in? You've got to then divert them into other locations. And some of them could be near if you're in an urban setting, but some of them could be, a couple hours away if you're in a rural setting. So you could have scheduled procedures that now have to be canceled or suspended until things recover in a meaningful way. So there's a number of different, effects to the overall care delivery system that could happen, whether it be a cyber attack or otherwise.
Yeah, operational, for example, as you started with. Have you seen any sort of research out there that kind of is a qualitative versus quantitative, sort of kind of survey findings, if you will?
Yeah, I love that question. Censinet did an early study with the Poneman Institute. We created the survey instrument. And basically, I had this thesis that, based on anecdotal information and otherwise, that ransomware and cyber attacks was causing care disruption. And so we asked the question, we were the first to ask it in a qualitative way back in 2021, whether or not you had a ransomware attack. And if you did, what did it do to care in terms of what was the disruption to care? And we asked around mortality rates. Was there an increase in mortality rates? Was there increase in diversion of patients coming in? Did you have to divert ambulances? Were labs canceled or scheduled procedures canceled? Right. So we got a really good sense of what was happening. I was blown away because I remember the mortality rate increase was like 21, 22%. And wow. My thesis was it was going to be like 2%, maybe.
Right. Sure.
Right. And so that was huge enough. Now it's qualitative, but shortly, days after we released that study, CISA released a study which also looked at causation between ransomware attacks and care delivery. And so that was much more of a quantitative study. So we took those two studies together. They pretty much supported this thesis that cyber attacks and specifically ransomware was causing significant disruption to care delivery.
Yeah. And actually, you just reminded me. So probably back around that time, actually, we had Josh Corman, who I think you know pretty well, right?
Yeah. Josh is the one that actually created the CISA report.
CISA side of it. Yeah, exactly.
Yeah. And I remember we released on a Wednesday and he called me up and he's like, what methodology did you use? And I said, well, it's qualitative. And he goes, well, we're going to announce one on Friday. We're going to publish one and it's quantitative. And the two together are going to support the case that, we've got a real issue in healthcare. And we need to do more around ransomware and cybersecurity. So, of course, I was excited about that as well, because knowing it's qualitative, it's directionally, there's still some value there. But when you have the two together,
exactly. And
then there were subsequent reports that came out as well. JAMA did a couple of different studies as well that proved there was an increase in mortality rates as well. So, you started to see more research. People were starting to ask the question. And I just found it curious that, no one really wants to know, because if there is a big problem, you got to do something about it. No, certainly there are people that want to know, but for the most part, we all sort of believe that was the case, but nobody was asking the question until, we did that study. So I was really surprised, but that became sort of this siren, this call to action, if you will, for the industry to start looking at this as a patient safety issue, not so much as a cybersecurity issue.
Yeah, which is really a game changer in the way you approach things, right? Yeah, to your point, 2%, sure. I would have been there right with you. Plus 20%, that is insane, right?
It's insane.
It is. Yeah. The impact is just unbelievable.
It's crazy.
One of the things that would be, I think, helpful for the audience also to kind of take away is your perspective again on just, maybe some practical ideas, motives of kind of operation to be able to help reduce the concerns around patient safety from a cyber lens, if you will.
Yeah, I think there's a lot to unpack there. I think, assess your organization and where you are in your ability to manage risk across not just your internal systems, but your third-party ecosystem.
Mm-hmm.
And what we found is most organizations are still in the Stone Age as it relates to risk management. They're still using outdated practices that include spreadsheets or phone calls or emails, or they might be using a first-generation system that's really just an application in and of itself that requires a lot of customization. But there are tools out there now that can drive significant velocity in the process so you can cover more of your organization's risk with less resources. You can take some of the people you have and you can redeploy them in higher value areas of the organization. But it requires, this isn't incremental. You've got to take much more of a transformative approach to looking at your program. And it does take leadership, right? Most people don't like change. Let's be honest, right? People
Right.
don't want to change. They don't want to change what they do. Certainly bringing technology in holds up a mirror to us, if we're doing the job and all of a sudden I've got technology, what are you telling me? I'm not doing my job right? And this is more about what's right for the organization and what do we need to do to move forward, right? Because if we don't get a handle on risk, it's just getting harder and harder. Now you got AI. AI
Yes.
is exponential to the attack surface that we've been dealing with over the last 5 years. You apply that and in order to drive business and to drive new business models for care, you have to look at AI seriously and apply it accordingly. But you can't do it out of the gate. You can't just drop it in. It's too dangerous right now. There's things we just don't know about AI, and there's things we do know which are, equally scary. So it does take a concerted effort. But there are systems out there and there are people out there that are doing it today. So tap into your networks, tap into folks that are doing it today and learn from them.
Absolutely. And so one of the things that we will definitely do is include the research that you guys conducted and link that back into the show notes as well. But I mean, Ed, just coming on, just shining the spotlight on this topic, which we've not talked about in quite some time, honestly, on the podcast, and is so critically important. I think the phrase you just said is it's not a cybersecurity issue, it's a patient safety issue. When we start thinking about it that way, let's look for good outcomes, obviously, and making it that much more of a focus for us all. So thanks again for coming on. Really appreciate your time.
Excellent. Thank you, Rob.